In these series of videos, I like to focus on male infertility or male factor infertility. I've worked in this industry for over 10 years now, and I can say that there is a lot of emphasis and focus on the female reasons for infertility, but the reality is 30 to 50% of the time it's actually not the female, it's the male. And male factor infertility is often sort of comes almost as an afterthought, and I certainly have seen patients where where the female has been assessed, but there's almost been no assessment in the male. So I hope these videos do give viewers a little bit of information about what are the broad categories of male infertility and how we assess and treat them. When we talk about male infertility, we categorize them into a couple of broad groups. The first one is sort of functional issues, so whether there is an issue with intercourse or around intercourse. The second category are probably the most common, where there are smaller issues around sperm, both in terms of the amount, the ability of the sperm to move, and the normal looking sperm. So these patients have sperm, but they're a little bit abnormal. In most of these cases, we don't find a reason for them. And in a lot of these cases, it's due to lifestyle and environmental exposures, and the treatment really is to try and reverse these as much as possible. There is a category of normal or normal sperm in terms of their examination, but really an issue with sperm quality, which is not always tested. And then the final category is that of people with no sperm, and that phenomenon is called azoospermia. Looking a little bit more into this category, certainly the most interesting of the categories and the hardest to treat. For the body to be able to produce sperm, there needs to be a couple of things that work. First is that there needs to be adequate brain signaling into the testicle. The testicle then needs to have the ability to respond to that signaling on a cellular level and produce the sperm. And then there needs to be the ability to transport that sperm from the testicle into the penis and out. So these 3 points of brain signaling, testicular function, and transport afterwards all can break down and result in no sperm. The causes of these are very many, and hopefully in the next couple of videos we'll expound upon them a bit more. Issues around testicular function and brain signaling come into the category of non-obstructive azoospermia, so no sperm, but not because of an obstruction. And then the next category is, of course, obstructive azoospermia. So nothing wrong with signaling, nothing wrong with the testicle, but an issue with the transport system. So how do we assess male fertility? I think the most important thing around assessing male fertility is a very detailed clinical assessment. So in that clinical assessment, we do ask questions around risk factors for testicular disease. So I'm particularly interested in any trauma and injury to the testicle, any surgery. We're interested in doctor-related, medical-related trauma to the surgery, to the testicle, including chemotherapy, radiation therapy. We are very interested in infections around the groin and the testicles, both at a young age and in adulthood. We do ask questions about intercourse, erection, arousal, ejaculation, and we are very interested in pubertal development of the male. When did we start growing quickly? When did we start changing our voices? When did we start shaving? All of these are potential indirect markers to point out how the testicle is functioning. Testicles also need to essentially leave the abdomen and drop into the scrotum, and that process sometimes is awry, and asking about whether that process was normal is important. General health is also important. There are various other health conditions that can affect the ability of the testicle to make sperm. We also ask about medications, and some medications do dampen the ability of the testicle to make good quality sperm. Family history may point to something that is genetic, that runs in the family, especially if there's a history of male infertility in the family. Occupational exposures is a really important but often overlooked aspect of male infertility. Tight clothing, types of physical activity, over physical activity, exposures to heat, exposures to radiation, exposures, and these things people don't think about because it's always what they've done is what they've done at work. But all of that can come into play. And of course, smoking, alcohol, recreational drug use. After we've done that, we generally would do a in-depth sort of examination. We would generally examine the scrotum and the testicle if on the history there's something suspicious for that. And the national guidelines do say at the very least in assessing somebody, we need to take a history and if necessary perform an examination. And that's been confirmed in guidelines all around the world. That's what should comprise of a comprehensive fertility assessment for the couple when they first meet their clinician. In terms of testing that we can order, obviously the sperm test. Sperm tests generally three main categories. They test the amount of sperm that is produced in that sample. It tests how much sperm moves, and especially sperm that moves forward, and it looks at sperm that is roughly the normal shape as a percentage. There are a few other things that they test for, including the amount of semen and so forth, but those three categories are the broad ones. Specialist labs, if there is an issue around sperm quality, will test something called a DNA fragmentation index. That is a measure of sperm quality. Keep in mind that sperm labs should have the ability, I should say, to process a specimen of semen pretty much straight away. If a specimen is left on a bench, for a long time, then that will adversely affect the outcome of the results that we see. So it's best to test the sperm in a lab that has the ability to process things pretty much immediately. Sometimes we need to do blood tests. As a rule, I generally do a chromosome check of all male patients that I see, and that's because chromosomal errors or rearrangements or subtle changes can affect the ability of somebody to produce sperm. And if there is a high suspicion for anything else, we can do a hormone profile. So all of these things comprise of a comprehensive assessment of male factor infertility, and really should be something that is standard for anybody coming through with inability to fall pregnant as a couple.